Hello, everyone. Hello, everyone. Hello, everyone.
Hi.
Thank you for joining. Hi. I see still a few people in the waiting room, so people will be joining. And we if we can ask people to mute themselves when they are not speaking, that would be great. We had about 60 people registered for today's forum, and there was a lot of good reactions. So I'm really looking forward to the topic of today. Today we're talking about the gender-sensitive, people-centered approaches to TB. It's a day before World Women's Day. International Women's Day is tomorrow. And the theme for International Women's Day is Inspire Inclusion. And as part of that, to link the TB work that we're doing, that we are all involved in, we thought we would link a forum and a discussion for everyone to kind of join, talking about the female private providers and also women that are affected by TB. So today, I'm really happy to open this forum, and I'm glad that we have a fantastic panel to talk to us today. I'll introduce them in a minute. Before I do that, I want to let you know that we're talking for about 1 hour. The chat is open to anyone to put any reactions, any questions. We will bring the questions up during the flow of the moderated discussion. You are also very welcome to raise your hand and ask a question directly. We will call on you. The session is being recorded and also live streamed on YouTube. You can use the subtitles at the bottom of the screen for your own use if you would like some assistance with the language. We will be sharing a news post in the beginning of next week on our website with some quotes and main outcomes of this discussion. And if you're not yet a member of the TBPPM Learning Network and are interested in more of these discussions, please feel free to join. It's tbppm.org. So now I would like to welcome our guests today, and I'm really thrilled that we have a great lineup of people. So with us is Busi Beko. She is a TB activist with TB Proof. She's joining us from South Africa. Her background is she's a social worker, and as part of her work, she is involved with many different topics. And she also had her own TB journey where she developed multi-drug resistant TB and struggled to get the treatment for her and her baby daughter. So we're really looking forward to hearing from her aspect, from her background with her own journey, but also with her work as an activist. And then we're also having with us today Pungudi. She's joining us from the south of India in Chennai, and she's working as a direct support to women who are going through the TB journey. And I'm looking forward to having her join. With us is her colleague and her senior, Dr. Radha Rangasama, who's working for REACH in Chennai. She's been for many years involved in REACH's excellent work in engaging private providers, female private providers, male private providers, public sector background in tuberculosis, and they've developed a holistic comprehensive program in Chennai that also includes a lot of community members, of which Pungudi is one of them. And with that, also a mentor-mentee program that we're looking forward to hear more about. So thank you for joining, Dr. Radha. And from Pakistan today, Dr. Sharaf Shah is joining us. He has a background in he's a director of the Institute of Nursing, but also the executive director of Bridge Consultants Foundation. And it is with that last hat on that we are talking to him. Bridge Consultants Foundation has done excellent programming in Pakistan with female private providers, reaching to some of the rural areas, especially women who are affected by TB, and have some great outcomes to share on how their program has helped to reduce stigma and help to increase more of an approach that joins, that makes women come forward when they have TB symptoms. So we'd love to hear about their program. And finally, I'm happy to introduce Dr. Carrie Millington. Carrie is a research uptake manager at the London School, and her current work involves maximizing the impact of research, and she's managing the LIGHT Consortium, which is a program between UK and UK government and researchers, as well as partners in Kenya, Uganda, Malawi, and Nigeria, looking specifically at transformed gender pathways for the health of tuberculosis. And as she's also a member of the Gender and TB Working Group of the Union, and I'm also glad that she's joining to give us more of a research and policy perspective to draw the attention to the topic of women and TB. So with that, I would like to start, and maybe I'll give the floor first to Busi. Busi, thank you for joining. Could you tell us about your TB journey and highlight to the audience some of the issues that you faced as a woman specifically? What were some of the challenges that you had to go through because of your gender, and maybe highlight how you resolved them together with your caregivers?
Thank you. Thank you for the introduction. Firstly, I'm gonna just give an overview of my TB journey. So I was pregnant with my daughter when I was first become sick with a drug-resistant TB. So I was so terrified. They told me my close contacts were at risk. It really does not get any closer than sharing the same body after all. And although I was coughing and losing weight, I was fear for what might happen to my child that preoccupied me most of all. How would the TB affect her? So would she get it too? That was my question every day. So would the tablets that I was taking to try and save my life end up hurting hers? So despite the fact that TB makes 10 million people sick each year, and thus I certainly was not the first or only pregnant woman trying to figure out how to manage the two very different passengers. One badly wanted, other most, with whom I was now sharing my physical form. I quickly found out that nobody in the clinic could answer my questions for me. Fragmented into adult and pediatric world as TB service are there, was nowhere I could turn. So I felt guilt, and the things that they were telling me in the clinic made me feel that like they were even more, since people with TB are often treated like nothing, like more than that they are like vehicles of infection. So meaning which like we are transporting the infection, because we're always told that like we are infectious. When my daughter was born, and unfortunately, she was also diagnosed with drug-resistant TB several months later. And then things becomes more difficult for me. Not only did I have my own health needs, but I also had to look after the needs of my child. Although we both did our best, she did not cope well with the treatment. She became like a zombie, sometimes struggling to take the process of getting care for her and for me. To deal with her as a child, me as a mother, or us as a family. And the tablets that she had to take did not come in a child-friendly version. They were so painful to swallow for her. I found them nearly impossible to prepare. And really, how do you measure like a 3/4 of a tablets? Because now I have to estimate and like break the tablet and give it to her. And I feared I was likely underdosing or overdosing her. I felt like I was set up to fail, but we fought hard, and both my daughter and I survived. So that's my story in a nutshell. And as I mentioned that like it was not really easy, because as you can hear from my story background, for an example, there was no person even at the clinic level to say like, now you've got drug-resistant TB and this, you must expect this and this and this on your TB journey. So meaning which like the council, the only thing that I was told of like kind of advice. It was the termination of the pregnancy. No one did check like my feelings. How do I feel? Like even like my norms and my values around that to do OTP. And also from there as a woman, there was no one who really cared to like maybe to bring like a family member so that we can also like give the information so that that person can like support you. So it was kind of like emphasizing or perpetuating the stigma to me, so that like I was stigmatizing myself because I felt that like being pregnant and being diagnosed with TB and also with HIV at the very same time. So kind of people like were looking at me to be like, you are sick, and at the very same time now you are pregnant. So as if like with the pregnancy, I was not supposed to be pregnant as a woman. So also with me having HIV while I'm pregnant, it was another like a mountain to climb, because having a HIV and TB, it seems as if like I was not like really behaving in a good way. So yeah, I could stop there so far. So that's my story so far.
Thank you, thank you. And you so beautifully describe how on so many aspects you were made to feel almost not human. And I think that is part of the reality that we're facing today, that the treatments that we have are not made for um, pregnancy, and they're not made for little children. And so you have, through the since your journey that was in 2015, right? When you, or before that, 2005, that's right. And since that time, you've become really involved in the work with TB Proof to let your story come out more, and to put pressure on governments and on researchers to develop better treatments for pregnant women, but also for little children. Can you just talk to us a little bit about some of the work that you do with TB Proof?
Yes, firstly, I was involved with MSF for 15 years working in a TB pilot project, especially the drug-resistant TB. So working there as a patient support counselor supervisor. So it's whereby like end up like gathering the patients that like have been diagnosed with drug-resistant TB. Through my experience, that like even for myself, I needed someone to talk to. So I organized those patients, had the support group so that they could be treatment literate, so that when they, for an example, they are experiencing side effects, they can open up. And also try to do the home visit, because for me, I felt that even for me, the part of like involving the family in my treatment journey was missed, so that they can support me. So I also did like the home visit for those families, so that they could understand and how to support, and also how they can protect themselves from TB. Because the only time that they know that this person is having TB is when this person is coming from the clinic telling them, and there is no more like other information. I was also involved in a community radio, whereby I was like having a radio slot, which was running 1 hour to talk just openly about TB. So people were interested, because you will think that people know and understand what TB is. But unfortunately, we are coming from the different cultures with different background. So we've got our own like explanation and understanding when it comes to TB. So we've got our own naming and labeling of TB. So some of these things are stigmatizing, and some of these things are discriminating, but not really, I could say people, they didn't understand. But the more you give them information, the more you give like educate them, they become more aware and like really come forefront and like of TB Proof, whereby we push like the advocacy agenda. Because I remember like in my time, we started like there were still like injections on the TB. So through my support group and through those like TB survivors, we did manage to come up and like really fight for injection-free treatment for maybe lesser duration and with less pill burden and also side effects, then it's whereby today, like, I could say I'm proud because, like, from those 15 years, we kind of like, yes, it's not a big push, but there is something because we manage, like, now the treatment is like having no injection and we've got like new clean drugs, but still there is a push, there is a lack on the side of like women, especially the pregnant women, because like the only time that you would hear about the pregnant women, it's only on the other platforms, not per se with when it comes to TB. When it comes to TB, even with the research, the researchers, like, they will tell you that like we don't have much more information about this drug, so we can't give you this treatment. So all these things kind of like really taking like the power from us as the women to be like, maybe we're not supposed to live really. We've got no rights to live because, like, in my imagination, how dare, for an example, now me together with my partner now we're diagnosed with drug-resistant TB and telling him that like, okay, you could benefit from this like clean good drugs, and then with me you're gonna tell me that like, no, we don't.
Lucy? I think we're having maybe connection issue. Lucy, we'll get back to you. You've given us so many points to think about and so many details to absorb, not
if,
just from
like,
your...
you get pregnant and they will like...
Sorry, Busi, I think we have a connection break. Let me thank you so much for sharing your, not just your story with us, which is really has so many aspects for us to think about, but also your work with TB Proof and highlighting the importance of educating and talking to people around these issues and really pushing for more attention to pregnant women. I appreciate your thoughts, and we'll get back to you in a minute. I would like to ask Dr. Radha. Dr. Radha, you're working in Chennai, and I think some of the points that you just heard from Busi are very familiar to you. The women that you care for have many of the same stories. And would you be able to tell us a little bit about how some of the stories of the women in Chennai that you've seen, and how REACH has tried to address a really a specific approach to support these women? And yeah, maybe we start with that question.
Yeah. So basically, REACH has been engaged with the private sector for the last 25 years. And we've sort of gradually expanded. We had just 4 centers, and now we have around 40 centers in Chennai. And these centers are called Nakshatra centers, which means a star. Nakshatra in Tamil or Hindi means a star. And each one of these has one of our staff placed in that center. And these centers are all situated in private hospitals. So we don't pay any rent. We want the private practitioners to come forward, feel a sense of responsibility and give us a space, so that we have a little place where we have placed the staff also there. And we make sure that we seamlessly provide quality TB care services. So I would like to tell you that we have around 40 staff, of whom 35 are women. And so it's just that I really cannot say what exactly is the reason behind it, but we do find that they are able to have an excellent rapport with the TB patients, be it men or women, because we come to the gender lens later. But initially, it is just having compassion, empathy, being non-judgmental in providing services. So, of course, we do come to the gender lens later, where the male patients have different issues, different problems. Many of them are migrants. They come here, they have a language barrier, where counseling is not possible, or they may want to move out and go back, or they need support here. So we do have issues with male patients also. And with female patients, as you know, our TB non-wins have an excellent rapport with the patient. This is what is, I would say, the highlight of the whole program. It is rapport building with, say, the female patients. It would be either it happens during one-to-one when they come initially for both diagnosis and for treatment support. And then it is followed up with home visits for them. And they're coming, the patients coming every 15 days to collect their medicines. So these meetings are used mainly for rapport building. This rapport building is very important, as we just now talked about a woman even being comfortable in talking about getting pregnant, being recently married. Can I get pregnant? So this needs counseling both for the patient as well as her husband. So we have a number of, when it comes to women, we have a number of problems. And unmarried women, for example, would be so afraid. Confidentiality is so important. She may not even want her other extended family members to know that she has TB, because, you know, here culturally in our place, marriage is so important. And so if a woman is labeled as having TB, the prospects come down. So there are so many concerns. Just coming to a simple thing, there are so many girls in the age of marriage where they get a cervical lymphadenitis, and they are not even willing to have an incision on the neck because it leaves a scar. So we have to talk to the private practitioner, saying just a fine needle aspiration will do, and then start the patient on treatment. So there is a lot of things to do for these women. And again, if they are married, again, that has got another whole lot of issues. Should my husband know? Should my in-laws know? Because I have the fear that I may be just asked to leave the house. I may be asked to go back to my parents' house. So what happens to my marriage? What happens to my children? If I have children, I may be asked to leave them behind. So there is a whole lot of issues which have to be sorted out. And I would say that it is so much case to case. If I have to quote these, there are so many such instances happening, and almost happening on a daily basis, where at times they call me in for some counseling. Suppose we just advise. Now, suppose I feel that the lady need not get pregnant during these 6 months, calling them and talking to them and just educating them, on, yes, because they would not like to terminate the pregnancy. So how is it that we can postpone their pregnancy? So these are all things which we talk about to the patients. But I would say that our female staff, they have an excellent, they go beyond the call of duty. It is, yes, providing medicines, providing diagnostic support, providing follow-up visits, providing counseling. But I would like to quote quite a few examples where they selflessly accompany. Suppose an expert advice is needed for a lady. As you know, being a woman, she is so dependent on her husband or her family to bring her or to take her to a specialist. There are many a times when our TB Nanban will say that, don't worry, you come to this place, I will take you for specialist consultation. I will see that, you are started on treatment. So they accompany the patient for referrals, to higher referrals, or even if any investigation is needed. They are so good that they can even talk to the private practitioner and even waive away the fees. Because though these people come to the private sector, it is not that they are very well off. They come due to various reasons, nearer home, suitable timings, known to them, or maybe a female provider is whom they want to go to. So they just enter the private sector, but the follow-up when investigations are needed, and also when an expert opinion is needed, they may not be able to afford these. So here is the TB Nanban, who is like standing rock solid behind her. Whatever she needs, I am there for you. So they are comfortable to call them at any time, call them at 10 o'clock in the night and complain of an adverse reaction, saying, I want to stop the treatment. I don't think I can continue. So these are the times I just find them totally standing with them and
Yeah.
helping them. And I can also just tell you that, this is proved by the fact that they almost become like a family member. You will find
Yes.
them asking us that I'm being invited for a wedding, I'm being invited for some functions, can I go? Because this is a very difficult journey. And definitely you need somebody with you all along, especially more in the initial stages and as you go along as well, like motivating you and making sure that you complete the treatment. So our TB nuns go and do so much. I have seen how I can, the rapport building is so good, because when we have a meeting or something, and then we just ask some of our female staff to call volunteers to talk
So
about
Dr.
their
Radha,
journey.
maybe this
Yeah.
is the perfect time to bring Pungudi in, because she works closely with you, right? Pungudi,
Yes.
I'm so happy that you're with us. Maybe you want to turn on your camera and unmute yourself and just follow up on what Dr. Radha has been talking about, and give us a little bit of your experience as TB Nanban, and some of the highlight some of the aspects that Dr. Radha has just mentioned. Pungudi, are you with us? I see that she's with us, but maybe she's not able to connect fully. We'll give her some space when
Sure.
I see her in the chat. So if anyone, if we can get Pungudi to speak, that would be great. We would love for her to hear from her experience directly. But I think you've done a beautiful job explaining how important the journey companion. I'm using that word. You are using a TB Nanban, which is a friend, right, in your language, and I think that exactly expresses the need of the care and support in a people-centered way, as you have brought into your program. And so, if anyone has any questions for Pungudi, please put them in the chat, because she's with us today, and if you want to hear some of her thoughts directly, that would be great. And Dr. Radha, thank you for explaining the program. And really, you have expressed, like, when people seek care in the private sector, that's where you meet them. And I think that is part of the beautiful thing of people-centered care. I'll get back to you. I would like
And
to
I'm
call
sorry, I'm sorry if I overshot my time, because
No,
I've just been.
not at all. It was all appreciated. We'll get back
Thank
to
you.
you. Dr. Shah, you're joining us from Pakistan, and you have a program with Bridge Consultants, in which you have a lot of female private providers also supporting the work. So I would love to hear from you to explain a little bit the program, and to how you center how your program has helped to center the women in Pakistan. And go ahead, Dr. Shah.
To understand the program, I will give you just little brief background. The biggest challenge for Pakistan to end TB is the low case notification rate and missing cases. We miss about 30% of incident cases almost every year. And majority of those missing cases are either marginalized population or women. And the notification rate in different districts for women is lower than men. So we started this program in 4 selected districts of Sindh province of Pakistan, where case notification rate was less than 50% overall. And then there was disparity between men and women who were notified. So there were less women than the men who were notified for TB. And then we explored and discussed the issue with the community. And it came to the front that majority of the rural women, these are the rural districts, majority of the rural women prefer to consult female doctors in comparison to the male doctors. They are reluctant to go, don't feel comfortable. So we started this program in these 4 selected districts. Okay, Kazam. 4 districts of Sindh province, and we engaged female doctors. Female doctors mostly in these districts are very few. They are not many. And then mostly they are engaged with the gynecological problems and the obstetrical problems of women. And then second is the pediatric patient they see. They don't engage in other diseases. So first task for us was to motivate the people, doctors to join the TB care. So we recruited about 95 female doctors in 4 districts after motivation, and then trained them on the national guidelines on tuberculosis. And then at the same time, we engaged the 105 paramedics who are working with these private practitioners or private doctors. Can you hear me? Hello?
Yes, we can hear you loud and clear, and it's very clear. Please continue.
Okay, so the program was we trained them on national guidelines, and then we had the same time program community mobilization. We involved the community leaders and civil society organization, and then we involved the National TB Control Program, because the medicines were provided by the National TB Control Program. And then we have collaboration with the Global Fund funded program, public-private partnership for the gene expert tests of these women who were diagnosed with tuberculosis, to know the DRTB, if there was cases, to refer them. So we were able to screen more than 200,000 women through these 95 female practitioners and 105 paramedics. And at the same time, we were able to diagnose quite few men also, who were the contacts of the index case of the female. And then we registered them for the treatment, and follow-up was again a challenge for us of these registered women, because traditionally in rural areas, women alone cannot go to the health facility. So we engaged the male members of those TB patients as the TB supporters. So they brought the patient to the health facility for the follow-up, and that we were able to successfully follow them for the adherence of anti-tuberculosis treatment. So this is just brief.
Thank you. That gives us a really, thank you so much, Dr. Shah. I think your program clearly has grown so much and is able to provide full-on diagnostic and treatment within a full program. And I'm very impressed to hear how you still remain with the focus really on the female patient at the center. And thank you for explaining that to us. I will get back to you. I wanted to call on Punguri because I can see that she's with us, and I just saw you pop the camera on, and I would love to give her a chance to say a few words as well. We will get back to you, Dr. Shah. Punguri, are you able to talk?
Yes, good evening, ma'am.
Good evening. Thank you so much for joining. So we heard from Dr. Radha and Dr. Shah, who both explained the program, how they put a focus and a center on women, and that's your daily work. So we would love to give you an opportunity to, for a few minutes, explain some of the highlights of your work that you're doing, and some of the important things that women patients in TB are asking for when you come and visit them. Would you mind sharing a little bit with us?
Okay, yes, ma'am. Okay. சார் நான் பேசலாமா?
பேசுங்க பூங்குடி, வெயிட் பண்ணிட்டு இருக்காங்க. உங்களுக்கு தான் வெயிட் பேசுங்க.
ஓகே மேம், ஓகே மேம். குட் ஈவினிங் எவ்ரிவன். சாரி, எனக்கு கொஞ்சம் கனெக்ட் ஆகிறதுக்கு ரொம்ப லேட் ஆயிடுச்சு. ஐ எம் எக்ஸ்ட்ரீம்லி வெரி வெரி சாரி. I am Pungudi from Vellore district, Tamil Nadu. I am TB champion and also the president of state level TB survivor network in Tamil Nadu. 3 times I get affected by TB. My health condition was very bad during those days. I lost my child and 2 times I get award. As a woman, I struggled a lot of faced so many issues during the treatment time. Initially, my mother-in-law and my husband to send me my father house. My husband and my mother-in-law stigmatized me, struggled using bad words, asking me to eat separately after everyone finished their food. And more as a woman, I am financially dependent on hands. I don't have any way to fight against them. Hence, I am positions to accept whatever they do. There is also no support from my father or my sister during those days. Finally, I got divorced to my husband. Now I am living with my father home. Till now, in my village, some of person are saying that she is TB patient, and they still even stigmatize me. They will not talk to me even now. I became TB champion in 2019, and I am now fighting against TB related stigma. Now my family is supporting me well. So thank you.
Pungudi supera pesina. Very good.
Thank you so much for sharing, and honestly, thank you so much. And you're doing fantastic work. And we really hope that the work that you're doing with Reach is giving you back some of the credibility that you deserve, because your work as a TB Nanban is fantastic, and will be supporting so many women in Chennai and area. So thank you, Pungudi. Thank you for sharing your story, and thank you for being with us. And thank you, Dr. Radha, for building such a fantastic network of women. I think this is exactly what we're trying to address today. So really happy to have you both with us and share some of this. I would like to bring in Dr. Carey just to give us the lens on from a global perspective, a little bit more of the research work. So, Carey, we've heard from some excellent direct experiences from women, and we've also heard some of the programs that are trying to address how we can best give care and how we can best provide support. I would like to hear from your side, maybe how can we ensure that research on TB and gender really informs some of the advocacy and policy and practice work, not just at the national level, but also at the global level? Before we jump back into questions from the audience, I would love to give you the space to talk a little bit about this.
Thanks so much, Petra, and thank you, Busi and Pungudi, for sharing your story, which is never easy, but also for your fantastic work in now becoming advocates, and then also hearing from Radha and Dr. Shah about their perspectives and the incredible work they're doing. I come from the research perspective, based here at the Liverpool School of Tropical Medicine, and I'm working on a programme with 4 African countries in Nigeria, Malawi, Uganda, and Nigeria. So taking the kind of step back and thinking about structures and systems that underpin gender inequality, also not only disadvantage girls and boys, but also harmful to boys and men and people of non-binary gender identities. Traditionally, TB programs have taken a biomedical approach in the TB response, with limited consideration of the different needs of women, men and people with non-binary gender identities. Dr. Shah touched on it, and globally TB does affect more men than women, with close to 6 million men affected, as masculine norms, behaviours and practices can increase their likelihood of exposure to TB while undermining their engagement with care. This affects their physical health, their mental well-being, but also their ability and capacity to contribute to their families and to their communities. But person-centred, gender-responsive care for TB should move beyond a focus on either men or women to recognise socially produced vulnerabilities of all genders. so that TB responses can address the needs of everyone in the community. This includes those who have TB, those who care for people with TB, within the family and community or within the health facility. We've talked about healthcare providers, and also those who are affected by TB both socially and economically. Sex and gender differences in disease patterns result from biological differences, but also from socially constructed gender norms, roles, and relations that drive gender differences in disease exposure, in their illness experience, in health behaviours and access to health care, but also thinking from the other side and looking at gender bias within the health systems, within research and within institutions. I work on a LIGHT research programme that I've mentioned, funded with UK aid, and we're trying to provide new evidence on effectiveness of different gender responsive pathways to health for those with TB in peri-urban settings. And this includes working with those in the community and with different stakeholders to identify what are the barriers for accessing care and trying to understand with those. And that involves participatory research methods with those who have TB, those who look after those with TB, and those both in the public and private sectors providing TB care. And then to explore with them what strategies they think might align and respond to those challenges that are faced and identified. We then want to develop acceptable, convenient and effective interventions to increase actively finding men with TB in the community, linking them with care in the formal and informal settings where they may congregate within densely populated settings, and also improving their access within the health facility. So kind of thinking about all the different contexts in where these people are, and then modelling, well, what might these interventions have on TB transmission, morbidity and mortality in the whole community? So what is the impact on men, on women, on children, everybody living in that community? But this research forms part of a wider conversation, including today, of how can we transform TB prevention and care to respond to the challenges that different genders face, whether you have TB, care for somebody with TB, or are affected by TB socially and economically. And by working together, both within the community at the national level and the global level, putting the voice of those affected by TB front and foremost, we can hopefully then develop interventions to ensure that we have gender equitable access to TB prevention and care. Thank you.
Thank you, Carrie. And you've said it beautifully, and I'm so happy that you're doing this type of research, because this will bring the many stories that we've heard today to the fore, and will help us to better provide this people-centered care. And you touched on, it's people at the center. It's not just women or men, and like both obviously have their own needs and their own struggles and their own barriers with access to care and treatment and diagnosis. But ultimately, you want to meet the people where they are and what they need. And so I'm really happy to hear you. Now, I would like to open up to the floor. I would love to hear some. I see some really excellent people have joined us today. Is there anyone who would like to ask a question, or would like to bring a comment forward, or wants to share something? Please feel free to unmute yourself and or put your hand up. Does anyone want to join the conversation or have a question? If not,
well, Dr. Shahina here.
Yes, Dr. Shahina.
I may.
Yes, go ahead.
I was associated with the Bridge Consultant Foundation and was associated with the project, and it is still is being implemented. I feel that it is a comment. I feel that stigma is associated with fear, and fear comes with ignorance. So we have to work to create the knowledge about tuberculosis, that it is not a dangerous disease. And we have to work with the community to increase the awareness about tuberculosis. only then we can fight the stigma, otherwise not. And there should be means to address this. This is my
Very
comment.
excellent comment. And I think this is also what Busi talked about when she started. And I heard the same from Dr. Radha. Can I invite anyone else to make a comment or a point?
I just wanted to comment on that, and I very much agree with that. But then something we found through our research is that also it's about providing opportunity for those affected by TB to kind of contribute meaningfully to the discussion and engagement. And often they're not given the opportunity to. And then when they are, they're kind of full of ideas and solutions that can, you know, really affect their community and thinking, well, actually, these are the stakeholders we need to be talking to. These are the policymakers or the providers, whether that be public or private. So it, you know, just to add on to the point that Shahina made is that, you know, it's also about providing that opportunity and providing the support and capacity for that meaningful engagement. And certainly from the researchers' side, it's making sure that we are communicating effectively to really make sure that they can contribute effectively.
Yeah, that's well said. Thank you. And Busi, you talked about it in the introduction. Do you want to give a quick comment? And then I'd love to hear from Shruti.
Yes, it is true that like we really need to include like the TB patient in whatever like things that we are deciding with them or about them at the clinics. The reason I'm saying this is because with my experience through my TB treatment, I could say like there are possible like mental issues that like are way far before like you start the treatment, because sometimes you've got psychosocial, I mean, psychological symptoms of stress. Sometimes you've got physical symptoms of stress, and then it's leading to changes in your behavior. So like now when I'm this kind of like isolated like TB patient, that is nowhere to run to. Even my family doesn't know what is happening to me so that they could support me. So really, what is going to happen? In most of the cases, that is whereby like we end up seeing people that like are really interrupting the treatment. It's because like they feel lonely, they feel like discriminated, they feel stigmatized. In my case, I was pregnant. Remember, like with the pregnancy on its own, you go through like sometimes being a woman getting pregnant without like a marriage. It's a taboo in my culture. So remember, now I'm carrying this struggle along, and then now you come and disclose that I've got drug-resistant TB, and also you tell me that like even my contacts are like really in danger of like getting the TB that I'm having. So after that, there is nothing. There is no communication. No one is saying like, for an example, these pills are going to harm your child, or these pills are going to do this and you must expect YZ. So honestly speaking, for me, I think if family-centered counseling, even not like a person-centered this time around, a family-centered counseling whereby like you're going to involve me as this woman, you're going to involve me with my child or with my like significant others, so that really they could understand, so that they could support. Yes, the doctors will be there, the nurses, the psychologists, whoever will be, but the people that I'm staying with 24/7, they need to understand, especially if like I'm free to come out to say like, look, I'm staying with so and so. Can't this information maybe to be divulged to so and so? That is an advantage. That is an advantage for me, because at the end of the day, like if my significant others know exactly what is going on, yes, they will support me. They will take care of themselves. Even for an example, today we are talking about ETPT. So how are we going to like really end TB if like we isolate TB patient and we like close them, like we give them the messages in the closed doors at the clinic? So family-centered counseling, I think it's a way forward.
So you're saying we all need to be much louder much louder about TB everywhere, all the time.
Yes, yes,
Yes.
yes.
I hear you. Thank you, Busi. Shruti, did you want to comment on this point too, or did you have a different question? The floor is yours. Go ahead.
Yeah, hi, thank you. I had a different thing basically, not exactly this point. So myself, Dr. Shruti, even I'm representing REACH. I'm working for REACH for the past 5 years. So what exactly, since we are working in the gender aspect for so many years, as in like what exactly I wanted to comment is especially about India, where we are working with so many millions of TB patients here. So, as in how much practically it is possible to really, as in like implement this gender sensitive or even gender responsive approach, as in where there is a scarcity for drugs and testing and all those which are like considering as essential things. And after that, probably this gender sensitive and gender responsive is the next approach, right? So probably like that's what in India, I guess, like, as in like gender sensitive and gender responsive approach, what we are talking here is practically not much applicable, which we all should think and probably work on, so that, as in we give that proper care and need for those people, especially women, when they actually are in need of. Probably since so many experts are there, I had this question as well as a comment that for a high population country like India, how do you suggest a gender responsive or else gender sensitive approach can be taken up or, as in applied?
Yes, I think that's a really good question. And I think several of the panel members talked about that it is really the people that should be at the center first. And the people need to be receiving responses and the support that is really required. And that is kind of the right test where they seek the care. That is the treatment where they seek care. And you're right that the extra layer of support is often a second thought, but in reality, that should be the first thought. We should really be talking about TB. We should be really decreasing the stigma. We should be really informing more widely so that we have a wide communication and that it automatically becomes people-centered. But I would love to hear from panel members if you have thoughts about this. Dr. Shah, maybe you also work with a large population in Pakistan. Do you have thoughts about this?
Yes, sure. It's very important. Community mobilization as was part of our project, and we involved the community leaders, and the awareness sessions were conducted with the female groups, and female community leaders were very active in that. And it helped a lot to refer these cases to the private practitioners who are trained on national guidelines. So community mobilization, especially involving the females, is must, community leaders.
Thank you. Thank you, Shruti, for asking this, for putting this point forward. So we have a few minutes left, and I would love to give all our panel members a chance to give us a final message. If you, and I'm going to go one by one, knowing that tomorrow is International Women's Day, and we want to inspire inclusion of everyone. We want to be loud about TB. What we want to make sure that everyone starts talking about tuberculosis so that, as you've all mentioned, that it doesn't become a stigmatized issue from our closed ones or even from healthcare providers. What is that we want this audience and more broadly people that listen to the recording, what do you want them to do tomorrow on International Women's Day? What's the message that you would like them to go home with today? Who would like to start? Busi, do you like to start? Sure.
Yes, for me, I would say, like, if we are serious about ending TB in all its forms, we must recommit ourselves, providing care for people where they need it the most, and not forgetting our so-called future leaders, that is pregnant people and their unborn child. Thank you.
Thank you, Busi. Dr. Radha? You're muted still.
Sorry. What I would say is that identify the felt need of the person. The person with TB has come to you, one, thing is providing drugs, providing support, but do go a little beyond. Identify what is the felt need of the person and make sure you provide that. Then they will automatically complete treatment and get better.
That's right. That's right. Punguri, do you want to say one word for, or one sentence for people to take away? We'll get back to you, Punguri. Maybe Dr. Shah? Oh, here you go. Sorry, I'm giving you the mic. Go ahead, Punguri.
பூங்கொடி, நாளைக்கு விமென்ஸ் டேல நீ என்ன சொல்ல விரும்புற? இந்த டிபியை வந்து ஒழிக்கணும்னா என்ன சொல்ல விரும்புற?
என்னன்னா டிபின்னா விமன்ஸ் தான் வந்துட்டு மெஜாரிட்டி, அது வந்து ரொம்ப பிரச்சனை வந்து இஷ்யூஸ் வந்து இருக்கு. ஓவரா வந்துட்டு விமன்ஸ் தான் வந்து இருக்கு. ஸோ இந்த விமன்ஸ் டேல வந்துட்டு டிபியால பாதிக்கப்படுற பெண்களுக்கு வந்துட்டு அவங்களுக்கு ஸ்டிக்மா இருக்கக்கூடாது, அவங்களுக்கு வந்து ஃபேமிலி சைடு சப்போர்ட் கிடைக்கணும். ஸோ அவங்களுக்கு ஹெல்த் சிஸ்டம் சைடு எல்லா சப்போர்ட்டுமே கிடைக்கணும். அவங்களுக்கு வந்து ஸ்டிக்மா அப்படிங்கிற ஒரு இது வந்து இருக்கக்கூடாது. ஏன்னா விமன் அப்படிங்கிறது வந்து அது எவ்வளோ பெரிய ஒரு கஷ்டமான ஒரு விஷயம் நம்ம சொசைட்டில அப்படிங்கிறது என்னோட ஒரு விஷயம். இதுதான் நான் வந்துட்டு நாளைக்கு வேர்ல்டு விமன் டேக்கு வந்துட்டு நான் சொல்றேன் மேம். நீங்க
சொல்றேன். நான் அவங்களுக்கு சொல்றேன். வாட் Pungodi wants to say is that on Women's Day, we all know that the problem with women and TB is very complex and it is a very big problem. So she feels that women should get a stigma-free environment, stigma-free treatment, and as well as support from the family and the health systems.
Thank you. Thank you, Pungudi, and thank you for translating, Dr. Radha. Carrie, what about you? And then I'll come to you, Dr. Shah.
I just kind of wanted to come with this final thought, responding to the last comment, in the fact that there are scientific advances in TB drugs, in TB diagnostics, and we are all hopeful of a new TB vaccine coming out. But, you know, people with TB have a right to that scientific advances, and that then focuses on ensuring that they then have access to these tools, which includes recognizing that socially produced vulnerabilities of all genders, so that those TB responses address the needs of everybody in the community.
Well said. Dr. Shah?
To the care of TB diagnostic and treatment care. So we have to address that disparity.
The disparity between, yes, you broke up a little bit. Maybe you can repeat it one more time.
Sure.
Okay, so we have to address the disparity between what people are needing and
access
and
to the
access.
care.
Yes. Okay, on that word, I want to give a big thank you to all our panelists for sharing your experiences, sharing your stories, sharing your thoughtful words and your input. And I've really learned a lot listening to each and one of you. Thank you so very, very much. We will be collating the thoughts. We will be making a lot of noise from now on, also on International Women's Day tomorrow, and we'll bring your stories to the fore. Much appreciated to anyone who joined today. This will be available as a recorded version, and thank you everyone for being with us today at this forum discussion. Really much appreciated. We will be having a forum where we will be continuing the conversation about support, and we'll be specifically looking at caregivers in April. And so look out for an announcement. We will be continuing the conversation. So with that, I want to wish everyone a big thank you, a happy rest of the day or evening, and good preparations for World TB Day. See you all soon.
Thank you. Thank you so much.
Thank you.
Thank you very much.
Bye.
Thank you,
Bye-bye.
everyone.